Hi, everyone. My name is Ishtar Govia. I am a registered clinical psychologist in Jamaica, and I am trained as a research psychologist. My training is from the United States of America. I live and work between Jamaica and the UK currently, and I do work related to dementia care improvement, particularly dementia care improvement in and for low and middle income country contexts. And I'm very passionate about care and care equity, about treatment options, about training of the workforce, particularly as is relevant for low and middle income country contexts. And why is that? Because the current and projected burden of Alzheimer's disease is disproportionately in low and middle income country contexts. We often associate awareness with changes in action. I'm a huge advocate for population level interventions. So levels that do not depend, interventions that don't depend on the individual to act, because if we're depending on the individual to act, quite often that does not necessarily occur. And those types of interventions also then, in a way, pathologize the individual. So you asked, for example, just now, why is it that women are more aware, but their prevalence of something like obesity is much higher? And the truth is, we don't know. We're really trying to understand this. And there is a lack of research that is focused on the populations in our context. So it's an enigma that we're still trying to understand. We've looked, for example, at things like environmental factors, whether it is that women are more physiologically prone to be having certain types of reactions to some of these environmental exposures that could be very context specific. And the truth is, we're not sure. We've also looked at the disproportionate, the imbalance, the inequity in terms of things like physical activity. Women are less likely to be physically active. They're much more likely to be sedentary. Women in our context as well are the ones that are turned to. They're expected to be the ones that are carrying things like norms for household food provision. And so if they're in the spaces expected to be preparing meals and doing those types of household tasks, sometimes they're not necessarily as focused on their own health and well-being as they are in terms of preparing for other persons in their family. So it's an enigma. We still aren't sure, but one of the driving factors is quite likely physical activity, low physical activity, and differences in terms of the types of diet that they're exposed to based on the context in which they're living and working. So those are some of the hypotheses that we're exploring. These are population level data that I shared. So these are from national surveys. It's not clinical data and it's not administrative data only. So it's not just persons who are entering into the healthcare system. So the data are population level, and so they're not biased in the way that you might expect some clinical or administrative data to be biased in terms of persons who are already in the healthcare system. Personalized medicine means that my understanding is that you'd be doing a battery of different tests on an ongoing, consistent basis so that you're actually able to tweak and adjust the type of care and the treatment options that you're offering to a patient. In our context, with the majority of persons who are below the poverty threshold, where they're using the public healthcare system, they're not able to get that type of regular, ongoing, routine investigations done. And so the type of care that they're able to get is not necessarily personalized to them. So they often have to wait a very long time to be seen in terms of the years, sometimes even for a particular investigation or particular operation if they are using the public healthcare system. And clearly that's not waiting for a test to be done, waiting for a surgery to be done. That's not necessarily the most ideal in terms of personalized care options. We do see in the private healthcare system, however, more persons that are able to have more regular contact with their physicians, to have more, and to if their physicians request these investigations, that they're able to follow up, get those results, get back to their physician more regularly. And so in the private healthcare system, there is, and in terms of the private healthcare services, there are more possibilities for personalized care. But the more we do that, the more likely we are to exaggerate and intensify this disparity that we're talking about in terms of what is available to those who have resources versus those who do not have resources. Because it's another example of why we cannot take a simply individualized approach to addressing these healthcare challenges, the dementia challenge in low and middle income country context. Because if we do that, we pathologize the individual. We also expect that the health service, we assume that the health service is actually going to reach everybody when in effect, it does not. The public healthcare service does not reach everyone, and private healthcare service is much more likely to reach those with resources already. So we exaggerate differences and inequities that are already there. And then why it's important to think more in terms of population level strategies, because those types of strategies that are more policy driven are, and that have attached to them the need to allocate resources for that. So if we're talking, for example, about healthcare system preparedness, how can you ensure that there are electronic health records in use in all of the facilities? Right now, those are really only existing in some private healthcare facilities. How can you ensure that we have the number of scanners that we need in all public healthcare facilities? There are very few of those that exist in public healthcare facilities. People have to go through private facilities and services in order to access those things. So I think in an ideal world, yes. But in terms of what we know will intensify inequities right now, I think that's something that we really need to be careful about. There are, for example, as we know, trials like the finger trial, and we want to explore and think about those types of things that can lead to individualized types and personalized medical treatment. But we need to do that in a way that's sensitive to the resource constraints in each of these contexts. I think the first thing I would suggest is just to listen, to ask questions and to listen, because somebody from Trinidad may have a very different experience than somebody from Jamaica, than somebody from St. Lucia, than somebody from Saba. So each of these Caribbean contexts, because the Caribbean is such a diverse place and space, it's English speaking, Spanish speaking, Dutch speaking, French speaking, Creole, and all of these, the differences in the language, the differences in the proportion of indigenous persons that are in those contexts, the diversity even within one Caribbean country in terms of their educational exposure, the year in which they may have migrated to the country in which that provider is working with them. All of those are very different types of circumstances. And so the first thing I would suggest is just listen and learn, because one Caribbean person, just like we say in dementia, one person living with dementia is not the same as another person living with dementia. And one person living with dementia at one point in the day is not the same as that same person living with dementia at another point in the day. So the first thing to do would be to listen.